Guys, I'm going to do Dr. Ringler's talk, which was on medications in IVF, specifically, what do we need, what do we not, and what can we eliminate. I'm going to try to make it a little bit less formal. If you guys have questions, just raise your hand. We'll address them as we get them. And again, we're going to try to encompass the broader scope of medication here. So the first thing I want to talk about is what happens during a menstrual cycle. A great deal of what we do in reproductive medicine has to do with the menstrual cycle, and we're trying to mimic it or use it to our advantage. When we look at the menstrual cycle, we start off with, at the beginning, the brain releases, so with the start of the period, the brain releases a lot of follicle-stimulating hormone. It gets multiple follicles to grow. As they grow, estrogen rises. FSH levels come down, and we select the one dominant follicle that's going to be released. And all of reproductive medicine basically plays off of this, so this is very important to understand. Okay, so if we go to, excuse me. Sure, okay, I'm sorry guys. When we prepare for a embryo transfer, there are two possibilities. We can do a fresh transfer or a frozen transfer. The vast majority of the transfers I do in my current practice are frozen embryo transfers. When we do a fresh transfer, it pretty much has to be a medicated transfer, especially when we're using a surrogate, because the surrogate's lining or endometrium has to be ready whenever the eggs, a certain number of days after whenever the eggs come out. So there's no chance of doing a natural cycle. The idea of synchronizing the two cycles without medication, it would be very difficult to do. When we do a frozen transfer, we do have the option of both a natural cycle or a medicated cycle. A natural cycle would be where we take the surrogate's own LH surge. We look for it both on ultrasonography and blood tests, and once we confirm it, then 6 days afterwards we can do a blastocyst transfer. A medicated cycle would be one that looks like this, and this really facilitates I guess it makes it very easy to do a transfer whenever we want. So at least starting about 4 weeks prior to the day we want to do the transfer, we start the surrogate or the potential patient on birth control pills. The birth control pills can last for any number of days, minimum of 4 or 5 days, all the way up to 2-3 months. It really is irrelevant. 25 days before we want to do the embryo transfer, we stop the birth control pills. 19 days before we want to do the transfer, we start estrogen, and 6 days before we want to do the transfer, we start progesterone. And then the lining is perfectly ready for a blastocyst transfer. When we talk about a surrogacy cycle, I think quite often we think that, well, we're going to have them use all this medication, how will that change things? But I think we also have to look at the whole. Surrogates are there to help you through this. They are, I think obviously they're being compensated, but there's an altruistic component to this as well. And when we try to nurture the surrogates through this process, we want to take into account their life, their commitments. Quite often, if we are doing a natural cycle, they'll have less than a 1 week notice when they need to clear out their schedule, get child care, have their husband miss his work, and drive them to the clinic appointment, and drive them back, and it really creates chaos in their lives. Versus knowing a month in advance, hey, this is the exact day of my transfer, I have my appointment already, let me get my child care organized, let me get my husband to get a day off from work. And in terms of success rates, they're no different, if not slightly better, I think, with medicated cycles. So I think that the vast majority of the cycles that are done in the U.S. are medicated cycles. Any questions regarding the two differences? Okay. Now, the medications that we use are estradiol and progesterone. It's the same molecule as made in the ovary itself, and birth control pills, which are a combination of estrogen and progesterone. Okay. Now, this is a picture of what the embryos look like, and I think to mimic what Dr. Kettle and what Dr. Feynman talked about earlier, we prefer to do day 5 blastocyst transfers. The vast majority of the transfers I would do have been PGS tested, and I think that a great deal of this has to do with the amount of aneuploidy that can be present even in donor cycles, and it can be up to 50%. I think in many ways I agree with Dr. Feynman that you can get decent success rates, but I tell you, after you've been through that much effort, decent might not be good enough. And by doing PGS testing, even if you get 10-15% better pregnancy rates for an extra $3,500, I think it can be well worth it. In terms of the medications used during ovarian stimulation, basically they fall into HMG, human menopausal gonadotropins. These are medications that are purified from the urine of menopausal women. We have recombinant FSH, that's FSH gene that's been transplanted into hamster ovary cells and purified from the medium. HCG, which is used for the trigger, but quite often we're using a Lupron trigger for safety aspects. There are two ways to prevent a person from ovulating prematurely. There's Lupron, which is a GnRH agonist. That's what we use in the US. You guys have a different product here in Australia. Then the antagonists, which are ganirelix and cetrotide. The Lupron, or the GnRH agonist, does cause an initial flare effect, and therefore can be used to trigger ovulation as well. Okay. These are additives that we can use to perhaps modulate the response a little bit, and Clomid can now be considered for use in perhaps older women that are only going to make a handful of eggs. So if somebody's going to make 3, 4, or 5 eggs, you can go through a pure Clomid cycle and get the same response as going through a cycle using 450 IUs of gonadotropins. It's pretty remarkable, and the cost difference is thousands and thousands of dollars. Tamoxifen is an analog to Clomid. We've started using more and more letrozole as well. Initially, we used it in women that had breast cancer because it actually prevents the production of estrogen and keeps the levels very low. But now we can add it to a cycle, any cycle, and get perhaps a little bit better response because the pituitary itself will make more FSH product. Okay, these are the various types of stims possible. And I think that this is a really important thing for us to consider overall. There's been a lot of talk about natural cycle IVF, and I think that there are indications if we're going to use a lot of medication, we're only going to get 1 egg. Well, you're going to get the same thing if you don't use any medication. And that's one of the rare times where natural cycle IVF would be important to consider. On the contrary, if you're doing it for somebody that has the potential to make more eggs, doing natural cycle IVF yields very low success rates because a lot of embryos are going to have aneuploidy, and not having more to work with just really limits your choices. There are a handful of clinics in the US that do this. They have the lowest pregnancy rates, and people wind up going through 8, 10, 12 IVF cycles. It's just a lot of effort to go through. What I define as a mini IVF cycle, and there are different definitions and one is not more valid than another, is where we just use oral medication, Clomid, etc., or Femera to grow the follicles. The Clomid or Femera has basically an anti-estrogenic effect on the brain, so the brain and pituitary itself makes more FSH. And with this, like I said earlier, you can get 3 to 5 follicles to grow. And sometimes this is a much better way to go than using a whole lot of gonadotropins that basically don't have any receptors to work on, and what happens is you wind up peeing out the medication. The way that I think about this is cups. If you think about the egg is surrounded by 2 types of cells, granulosa cells and theca cells, and these cells have receptors on them. And think about the receptors as cups, okay? And you're going to pour water. If you use a lot of hormones, all you're doing is pouring a lot of water over these cups. But if there are only 3 cups, they're the only ones that are going to fill. What happens to the rest of the water? It's peed out. Okay, there's nothing for it to act on. And that's, I think, a very valid way to kind of model this in your brain. More and more medication is not going to result in more follicles. And the treatment plan that we come up with has to be appropriate for that individual situation. But I think quite often less can be better. In terms of a stimulated cycle, I'll go through a model of that. And other options, like I said, we can do a combination cycle, and sometimes we can consider adding human growth hormone to try to improve the outcome. many years ago, I would talk about the 3 potential types of stimulation protocols: the Lupron downregulation, which is the most traditional, the antagonist protocol, and the Lupron flare. But I think the vast majority of IVF cycles done in the US today are the antagonist cycles. So I'm going to focus on that because most of the cycles that we do are modulations of those cycles. Okay, and this is a schematic of that. A lot of this IVF cycles do start off with a short course of birth control pills. However, in women that that have diminished ovarian reserve, that don't have a lot of follicles to work with, using birth control pills, especially a prolonged course, is a very detrimental thing to do because it does suppress the ovary, and by suppressing the ovary, we do limit our follicular response. Okay, after we stop the pills, we do want to give some time for the ovaries to wake back up. Usually that's 5 days or perhaps a little bit longer. And then we start the gonadotropins. Those are the injectable medications. They last approximately 10 days. And it's those initial stages, that first 5 or 7 days, if we want, we can add Clomid, or during that time, if we want, we can add a human growth hormone. So about halfway through, about 3/4 of the way through, we add the antagonist that prevents early ovulation. And at the end, we trigger with HCG or Lupron, depending on the estrogen level and the number of follicles. And then about 35 hours, we do the egg retrieval. Guys, that's the end of the talk. I hope it's been a very brief kind of overview, and I wanted to run through that so we have a little bit more time for questions, because I know that there are a lot of nuances, and I wanted to address those individually. Yes, ma'am.
Just interested in a medicated transfer. What sort of side effects do surrogates commonly get from that?
I think that's a great question. So the medicated cycle, I personally don't like to use Lupron or an GnRH agonist to that preceding the cycle. So basically, the side effects that a woman would go through being on birth control pills. Some women get nausea, but most women don't have any side effects. And then they go on estrogen. Estrogen can again cause nausea. It does have a chance of increasing the risk for DVTs, deep venous thrombus, or pulmonary embolus, but that is rare. And then progesterone, breast tenderness, those kind of side effects, but it's very similar to what they would experience during their own menstrual cycle. Yes, yes, sir.
Congratulations for your presentation.
Thank you.
In the protocol for artificial preparation of endometrium in order to transfer frozen embryo.
Yes, sir.
You mentioned estradiol 19 days plus. Have you already used CNR releasing analogs in the previous cycle?
No. I avoid all GnRH agonists. I haven't used a GnRH agonist to prime a surrogate in perhaps over 4 or 5 years. So once we start estrogen, we start on a fairly high dose, and that prevents follicular development, so we can forego the use of a GnRH agonist.
All right, thank you.
Just over here.
Yes, ma'am.
I was just wondering if you ever do a natural cycle for a fresh transfer where the egg donor or the intended mother has their medications for their egg collection timed to the natural cycle of the surrogate or the intended mother?
It's incredibly difficult to organize. I think that even a 1-day difference between when we get the eggs out versus when ovulation occurs can change the endometrial receptivity. And I think that with so much on the line, emotional, financial, it's just not worth that variability. Okay, good question. Any other questions?
With a surrogate, how important is it to have like a mock cycle before the...
I personally don't do mock cycles. I think there might be a diversity of opinion on that one. My feeling is that these are all proven, for women that have had children on their own, and it's highly unlikely that they're going to have issues. They go through a uterine evaluation, they go through saline ultrasounds, etc. The only time I would consider a mock cycle is if something has been done to damage the endometrium. Let's say they had retained products of conception after delivery and they had a vigorous D&C, something that would indicate that the uterus might have been compromised. If all they've had is a few vaginal deliveries, then a mock cycle is really unnecessary because they've proven their fertility already, and it leads to a lot of wasted resources, a lot of wasted money, time and effort.
If a surrogate was postmenopausal, and I'm not sure if that's something that you would consider, is there a difference in the medications that you would be using?
No, you can use it, but let's say if somebody's gone through early menopause in her 30s and she wants to then be a surrogate, that you can definitely do that. What you do want to do is put her on perhaps a serial estrogen progesterone program for a month or two leading up to the transfer cycle to get the endometrium primed and ready to respond. What estrogen does is it upregulates its own receptors so that the lining is more apt to respond in a timely fashion. And if they haven't had estrogen for a long time, then that response can take a little bit longer and can throw off the schedule. Okay. Any other questions? Excellent. Well, guys, thank you so much for your time. Really appreciate it.